Perioperative anxiety is associated with consequential perioperative outcomes, including an extended duration of anesthetic induction and postoperative recovery. Higher anxiety levels can lead up to higher incidence of emergence delirium, postoperative pain, and higher use of analgesics. Preoperative anxiety and disorientation are well known to be important risk factors for postoperative agitation, which affects children more often than adults. Emergence delirium is 3.5 times more likely to be brought on by perioperative anxiety, according to research. Younger age is also a risk factor for emergence delirium, especially for preschool age boys under the age of 6. The frequency of emergence delirium is greater in anesthetic drugs such as desflurane and sevoflurane, some gases that we use, midazolam, remifentanil, propofol, ketamine, and barbiturates. In this video, we talk about mitigating perioperative anxiety and emergence delirium using intranasal dexmedetomidine. Although intranasal dexmedetomidine is considered FDA approved in procedural sedation, there is no clinical practice guideline currently in North America that is used for perioperative anxiety and emergence delirium. Intranasal dex is an alpha-2 agonist that has sedative, anxiolytic, and analgesic properties. It mimics the physiological phase 2 sleep. With the intranasal route of dexmedetomidine, it helps minimize respiratory depression. It is also colorless, odorless, and non-irritating. These properties listed make it an ideal drug in the perioperative area to administer specifically to the pediatric population. Current literature has shown that the dose of dexmedetomidine through the intranasal route should be about 1.5 to 2 mics per kilogram. In this small segment, this is a brief video of an atomizer being used and how the administration of a medication through the intranasal route is absorbed systemically in the body. Current literature has shown that intranasal dexmedetomidine has a high bioavailability, rich permeability, and rich vascularization. In one study, it has been shown that the use of 2 mics per kilogram of intranasal dexmedetomidine for nasal sedation had a higher success rate of 69.4% higher than its competitive agents such as oral midazolam and ketamine, as well as chloral hydrate. Now, intranasal dexmedetomidine is a good drug that can be used in the pediatric population, but it is also essential to know how to administer through the intranasal route. It should be important to note that this specific device, the atomizer, can be known as many different names. For instance, it can be called a mucosal atomization device, a nasal atomizer, or the abbreviation of MAD. Key thing to know about the atomizer is that high applied pressure ensures that drugs are atomized into a fine mist of particles through the tip of the plug. The atomization spray atomizes drugs into a fine mist of particles to about 30 to 100 microns in size. Also, it is to include that there's a soft conical plug at the tip of the cone where this plug forms a seal with the nostril preventing any expulsion of the fluid. It also includes a malleable stylet that allows 180-degree positioning of the nasal plug. And as well as the syringe, which is a 1 ml syringe that is commonly used, helps enable the accurate measurement of drugs that will be delivered. It is important to note that dexmedetomidine, the vial that it comes in, can vary, but most commonly the dosage is usually 100 mics per ml that it comes in. To begin, you want to aspirate at least 0.1 mLs extra to fill in the dead space between the MAD atomizer. It is also important to note that manufacturers of the mucosal atomization device have recommended that when drawing up medication, you should add an extra 0.0 mL to the dose to take into account of the dead space of the atomizer. And also verify your drug concentration, and the dose that should be given to the patient. Next, you're going to aspirate the air, which should be the given amount that you are going to administer to the patient, into the syringe. Once the medication has been drawn, be sure to dispose the blunt needle tip into the sharps container. Once completed, be sure to place the MAD device on. It is also connected as a lower lock as any other blunt needle. Be sure that it is placed on properly. When administering the drug, you want to make sure that you have a firm grasp on the patient's forehead with the palm of your hand to make sure that you have stabilization of the head. As you are getting ready to administer, be sure when placing the device into the nostril that you are not shoving it or using force. The seal should be just enough to place into the nostril. Be sure to deliver equal amounts in both nostrils, as you should not exceed more than 0.2 in each nostril. Once completed, place the patient on their side. Alternatively, you can use the syringe to directly drip the medication into the nasal cavity. Be cautious of your dosage in each nostril. Tidbits to follow prior or after administration or to keep in mind is that with this drug, you can possibly see different arrhythmias such as AV blocks or bradycardia, as well as hypotension. Though rare occurrences have occurred in many studies, it is still possible. In conclusion, the utilization of intranasal dexmedetomidine in the perioperative setting represents a promising strategy for mitigating anxiety and decreasing the incidence of emergence delirium among patients. The evidence suggests that dexmedetomidine sedative and anxiolytic properties administered through the intranasal route offer an effective means of calming patients before surgery while minimizing the risk of adverse reactions associated with traditional sedatives. By targeting both anxiety and emergence delirium, intranasal dexmedetomidine not only improves patient comfort and satisfaction, but also enhances perioperative care outcomes. Moreover, its non-invasive administration route makes it convenient and well tolerated, particularly in settings where intravenous access may not be readily available or desirable. Although further research is warranted to optimize dosing regimens, evaluate long-term effects, and explore its potential in different patient populations, nonetheless, the current body of evidence underscores the promising role of intranasal dexmedetomidine in the pediatric population as a valuable adjunct in perioperative care, offering both clinicians and patients a safe and effective option for monitoring anxiety and reducing the occurrence of emergence delirium.